Distinguished professors, today I would like to present a topic regarding the treatment of OSA. Specifically, we will cover CPAP as well as other comorbidities like insomnia. There is a therapy called cognitive behavioral therapy. It helps patients not only with treatment adherence but also supports cases comorbid with insomnia. In today's presentation, I will have two main parts. One is about CPAP treatment adherence in OSA patients, and the other is a condition called comorbidity between OSA and insomnia. So first, we will look into what CBT is and how it is applied to OSA patients. The term CBT itself consists of two main components. The letter C stands for cognitive. The second is regarding behavior. Cognition refers to conscious mental activities such as thinking, understanding, or learning about a certain issue. Secondly, behavior refers to ways of acting. What is therapy? In CBT, is a psychological therapy, and the word therapy here means talking to clarify and treat mental or emotional disorders. Abbreviated as CBT, thus, we translate it into Vietnamese as cognitive and behavioral therapy. However, for a patient to respond to this therapy, a change is needed, and it is not like medication where you take a pill for a week or two, or in psychiatry, where an average of 2 weeks becomes significant. In cognitive behavioral therapy, it follows multiple stages. And if we want to change cognition or behavior, such as a habit, it requires several steps. For example, first is awareness, then attempting to change, preparing for action, and finally maintaining that action. For instance, with an OSA patient, they must realize how important the pathology and the treatment are, prepare mentally to use it, have the understanding to operate the machine, and most importantly, maintain its usage. This is not only for patients but also for medical staff who prescribe devices for patients. And how can we establish and maintain a new habit? Psychological studies often cite a figure of 66 days on average to form a new habit. For instance, with exercise, it is not something we can maintain in just a day or two. It must be done regularly with a routine and at a fixed time to sustain the habit. There is another term you may hear, which is CBT-I. The I stands for insomnia, specifically used for sleep loss. CBT is a general psychological therapy and it is one of many different therapies. For example, in medicine, we have internal medicine, surgery, and different regimens like A, B, and C for a single condition. So, CBT is one therapy among many for psychological and psychiatric treatment. CBT-I is for insomnia, and we can adapt this CBT-I not only for insomnia but also for other disorders or comorbid conditions, such as comorbidities. For medical staff, even if you haven't been trained in psychology, you can still absolutely use the techniques within this therapy. Because talking about therapy is like talking about a treatment regimen, and techniques are the medications within that regimen, so we can use them individually rather than using the entire therapy at once. When we Google CBT-I techniques, it shows there are many techniques included in the CBT-I therapy. But in reality, we do not need to use all of them. First of all, before using these therapies or techniques, we must have an appropriate diagnosis, meaning the diagnosis of OSA, sleep disorders, or insomnia must be accurate. Sometimes it could be a circadian rhythm disorder, or sometimes it could be other syndromes like restless legs or parasomnias. Second, it is necessary to listen and provide feedback regarding needs, expectations, and difficulties. This may be a bit difficult for hospitals with a very high frequency and large number of patients, as it is hard to find the time to listen. But what does active listening with feedback mean? When we hear a statement, we can provide feedback or paraphrase what the patient said to ensure they know the doctor has listened and understood their issue correctly. If we have misunderstood, the patient will correct us, helping us grasp the problem more accurately. Well then, we need to have knowledge about the pathology, insomnia, OSA, and other treatment techniques. For example, through courses from the Vietnam Sleep Medicine Society with instructors like Dr. C, or basic CBT techniques. The issue for OSA patients in this technique is, as the name suggests, related to cognition and behavior. Regarding cognition, Firstly, it is about how serious the disease is and how it needs treatment. Secondly, it is about what normal sleep is like. Sometimes OSA patients have apnea for so long that they become accustomed to that feeling of sleep. Until they receive treatment, they realize, oh, the sleep after treatment, the sleep with CPAP for instance, is what true sleep is. Before, I felt like I was sleeping, but it wasn't actually good quality sleep. And behavior refers to treatment adherence and habits that are not good for sleep. For example, sleep hygiene. So, for these issues, we will use some basic cognitive and behavioral techniques. In fact, we healthcare professionals and doctors have already been using many of these techniques, we just haven't named them yet. When we consult about the disease so the patient understands, that is cognition, we help the patient change their behavior. When we change the diet of an obese patient, as Dr. Ba mentioned earlier, that is also about behavior. As for other techniques, such as in cases of comorbid OSA and insomnia, COMISA, we will be more specialized by using CBTI techniques combined with OSA treatment, depending on the severity and the patient's comorbidities. What are the issues regarding CPAP in OSA patients? As mentioned in the presentations yesterday by the professors and today by Dr. Hoang, we know that the adherence rate is very low and varies significantly depending on the patient group. In reality, to achieve an adherence rate of at least 4 hours per night and over 70% of nights, only about 29% to 83% of patients are non-compliant with CPAP. Meaning the likelihood of patients being non-compliant is very high. So, what are the factors that influence CPAP adherence? First are the social factors. Patients arrive having no prior knowledge about CPAP. Patients feel that CPAP is something quite intimidating, and there is also the issue of cost. There are many barriers, or families may not understand these issues when patients wear CPAP. Psychological factors include the patient's feelings of embarrassment, fear, and the stigma of using CPAP. Patients will not feel comfortable using CPAP. Regarding physical comfort, there are issues like air leaks, aerophagia, or other effects when settings are not properly adjusted, and mechanical issues also affect the settings within the CPAP, which are the doctor's area of expertise. So, regarding behavioral intervention for sleep apnea patients, the American Academy of Sleep Medicine, AASM, strongly recommends educational interventions when beginning PAP therapy in adults with OSA. This PAP includes CPAP or other treatments like NIV, depending on the patient's severity. It can also be applied to CSA, or central sleep apnea. There is a syndrome that can significantly affect patients, which is claustrophobia, affecting about 33% of OSA patients according to a 2016 study, and it often occurs in patients with a history of claustrophobia, such as when using elevators or sitting on public transportation. I have patients who, when going through the tunnel in Saigon, there is a tunnel under the river, feel very afraid upon entering it and have to take a different route even if it is longer. Or patients who have a specific phobic reaction to CPAP will avoid it or use it very little. They will have anxious reactions when using CPAP, taking it off immediately after putting it on, feeling very afraid when using it. There are even patients who, upon seeing the CPAP, refuse it immediately. I will never use this machine, it looks too terrifying. For treatment, there is a technique called desensitization. This term is quite similar to the one used in allergy and immunology, where we allow the patient controlled, gradual exposure until they feel they can adapt to it. Here's a clinical case of a 52-year-old man who felt he couldn't use CPAP because he couldn't tolerate the mask, meaning he couldn't wear it, and his AHI was very high. His Epworth Sleepiness Scale score indicated excessive daytime sleepiness. I am uncomfortable with anything covering my head, even wearing a hat. It sounds a bit exaggerated, but since that is what the patient says, we listen. Even breathing normally is already uncomfortable enough. How can I breathe wearing this? How can I sleep? Quote, it sounds like there are some inconsistencies, right? But regarding those very inconsistencies, if you are a doctor, you would immediately ask, well, have you ever worn a helmet when going out? And during COVID, did you wear a face mask? These are the basics of our cognitive approach. When we refer to that technique, even if they are just normal conversations, it is called cognitive restructuring, which means adjusting the perceptions that the patient has exaggerated to bring them back into balance. So, this patient's issue is claustrophobia. This is just a preliminary assessment, not a psychiatric or sleep anxiety diagnosis. And we will educate the patient. These are things that doctors have already been doing. Announce the results of the respiratory polygraphy, disease severity, basic knowledge about OSA, progression, consequences of the disease, treatment methods, and summarize patient feedback. It also gives the patient an opportunity to reflect on what they have heard and understood, allowing us to verify if it aligns with what I have said or what the doctor has shared. Or if there are any discrepancies in the thinking between the patient and the doctor, where I haven't understood the patient or vice versa, we will adjust at this step. That is active listening with feedback. There is a CPAP desensitization technique. This is just a sample. It involves several steps to gradually expose the patient to CPAP until they get used to using it. The first step is to help you get more comfortable with CPAP while awake. For some patients, it is very uncomfortable. If the patient is already able to wear it, we can skip steps 1 and 2 to proceed directly to sleeping with CPAP. At this point, you don't need to wear the CPAP while sleeping. You can wear the CPAP during the day while you are working or watching TV. Step 2. Turn on the CPAP machine. Now you start by pressing the button. The previous step was just to wear it to get a feel for the machine. In step 2, we turn on the CPAP machine, hold the mask to the nose and mouth, and don't even need to fasten the straps if the patient doesn't feel ready. Just start from 1 to 5 minutes and gradually increase the time. Step 3, we will fasten the straps. An additional step is to fasten the straps over your head and wear it longer until the patient feels comfortable for 15 to 20 minutes. Step 4 is to turn on the CPAP and wear it during a nap. Now we start sleeping, but just a short nap, allowing the patient to rest comfortably and relax on the bed. Can I sleep? Sleeping is fine. The goal is not to sleep. The goal is to get a feel for it. Step 5 is to turn on the CPAP and wear it during night sleep. But we don't require the full 4 hours or the whole night yet. Whenever you feel uncomfortable, you can take it off. If this step cannot be carried out, then we take a step back. Like the process of establishing a habit or a behavioral issue, we will allow the patient to return to the previous step before continuing with the current one. And this is completely acceptable. We don't demand that the patient achieve immediate treatment adherence in the very first few sessions. Usually, the first week is the most uncomfortable for the patient, and whether or not they decide to continue is often determined during that first week of trying the machine. Second is the issue of comorbid insomnia and OSA, called COMISA. We have talked about the behavioral aspect of CPAP for a difficult patient, right? As for regular or standard patients, we have different methods. For COMISA, the rate of comorbidity between OSA and insomnia is quite significant, at 30 to 50%. And there are overlapping symptoms between these two conditions. These are the daytime symptoms. However, for people with insomnia, they sometimes don't feel very sleepy during the day. They feel a sense of restlessness, discomfort, and difficulty concentrating rather than sleepiness. Meanwhile, people with OSA will usually doze off during the day, and those with insomnia, especially related to anxiety, cannot sleep during the day even if they try, but they feel very restless and uncomfortable. They often have episodes of waking up in the middle of the night or have non-restorative sleep, feeling unwell upon waking. These are the global recommendations for treating insomnia. This includes the 2017 recommendations from the American Academy of Sleep Medicine. These are the medications that are recommended and those that are not recommended. But in reality, in Vietnam, some of these are available. For example, Z drugs are mainly sedative drugs or benzodiazepines, but there are many types of benzodiazepines. And here, we do not yet have strong recommendations regarding medication. Although widely used, colleagues and clinicians who prescribe medication will notice difficulties with long-term use, especially since chronic insomnia is defined as lasting over 3 months, at least 3 times a week, making it very hard to stabilize medication. Starting from 2019, guidelines in the US, and later in 2021, European guidelines, have reached a consensus on cognitive behavioral therapy for insomnia. That is a strong recommendation for treating insomnia. However, this is a multi-component therapy, meaning the entire approach that Key shared earlier. As for the individual components, they are actually fine, meaning they are decent. Having them is still better than not having anything at all. For example, brief consultations or therapies, these therapies we will discuss in upcoming slides, or what is known as sleep hygiene. But sleep hygiene on its own is merely a piece of advice, is not strong enough. There is a three-factor model, essentially the Spielman three-factor model, which is the mechanism used in cognitive behavioral therapy for insomnia. It involves 3 Ps, which I have translated into 3 Ks in Vietnamese for clarity: predisposition, provocation, and perpetuation. Each of us has a threshold for insomnia, and if we don't normally suffer from it, this predisposition is not rare. Except for cases of genetic or familial insomnia, very few people reach this threshold. Usually, no one develops insomnia solely due to this predisposition or constitution. These predispositions include being sensitive to sound or light, being prone to anxiety, overthinking, chronic pain, or depression. When encountering patients with a high predisposition, meaning a little bit of noise, a little light, or a small issue makes them worry excessively, the likelihood of needing medication treatment is higher than behavioral therapy. Secondly, for someone with an average disposition, certain triggers can lead to acute insomnia at some point. These include issues like stress, changing jobs or housing, the loss of a loved one, pregnancy or postpartum, psychological or physical trauma, illness, or post-hospitalization, which can all lead to insomnia. However, after that, the stress will eventually subside. It is rare for these stressors to last indefinitely. The stress will gradually decrease. But another issue arises: factors that prolong this insomnia, which are habits that keep us from sleeping well even though we think they are good for sleep. For example, tossing and turning while trying to force oneself to sleep. If you can't sleep, what should you do? You have to try to sleep, right? Because if you don't sleep, you'll be tired the next day, and the more you try, the more stressed you feel. Especially since the more you lie still, the more your brain stays active and alert. Or having habits like sleeping too much during the day to compensate for the night. But unintentionally, when you sleep too much or too late during the day, it becomes difficult to sleep the following night, and as it goes on, it turns into chronic insomnia. Or factors like poor sleep hygiene, such as consuming tea or coffee too close to bedtime. We have patients who, though it sounds strange, drink coffee at midnight, saying, "I can't sleep, I don't know what to do, so I sit there and drink coffee." After that, we also see these as very fundamental factors. Regarding the word insomnia, there are more specialized techniques for this specific issue, including components of cognitive and behavioral therapy. When talking about situations in insomnia, these two are commonly encountered. First, it is 1 a.m. and I still cannot fall asleep. Normally, I would be asleep by 10 p.m. For months now, I haven't been able to sleep, so I feel anxious that since it's so late and I'm not asleep, how will I be able to work tomorrow? So I will have feelings of anxiety, and my behavior will be tossing and turning in bed to fall asleep. Or perhaps not tossing and turning. Tossing and turning is actually still better than lying still and trying to sleep. Because the quieter our muscles are, the more our thoughts take over. And at that point, they race constantly like a wild horse. It keeps racing, and we are unable to drift off to sleep. The second factor, the second situation, is usually having stayed up all night before. Today I have to make up for lost sleep because I feel very guilty toward my body. If I don't catch up on sleep, my body will feel exhausted. So I sleep until 4 or 5 p.m., which is like eating a late meal. How could I be hungry for the next one? Sleeping too late means we will naturally have trouble sleeping at night, which relates to the physiological mechanisms of sleep hormones throughout the day. This C is cognition, and this B is behavior. So we will target one of these two factors. Actually, cognition is harder to change than behavior. The summary of the CBTI therapy is that we target behavior. Stop lying in bed, go do something else, or don't take naps, stay alert and do other things during the day. Or the cognitions and cognitions are even more complex. And to monitor patient sleep issues using CBTI therapy, a sleep diary is fundamental, and this is a chart I translated from the AASM. Suppose the other day, I had insomnia. I went to bed at 9:30 but didn't fall asleep until 11 o'clock. Then at 2 or 3 a.m., I woke up. The white spaces are when I was awake, and the black parts are when I was asleep. And then I woke up at 6 a.m., but I wanted to linger in bed a bit more. I didn't get up until 6:30. Then I napped a little at noon. So here there are formulas. For example, the sleep duration, called total sleep time, which is the total time actually spent sleeping, that is, the black parts here. Second is the time spent in bed, which is from when you get into bed until you get out of bed, for example, 9 hours. So we have a formula for sleep efficiency, and it calculates to 66.7%. This is just an example. In practice, we will do this for at least 1 week, and usually 2 weeks. We take the average to calculate this sleep efficiency. One of the components of cognitive behavioral therapy is to reduce the time spent in bed. Now, if I want to succeed in sleeping, I must increase this efficiency. So, to increase sleep efficiency, I have 2 methods. One is to increase sleep time, and 2 is to decrease the time spent in bed, right? And an insomniac cannot increase their sleep time without using medication. Therefore, the only way is to reduce the time spent in bed. And by doing so, we will increase this sleep efficiency. As sleep efficiency gradually increases, it will make the patient feel successful. From there, the patient will stick to this therapy when they see these numbers changing each week. However, it is actually not easy to fully implement a complete cognitive behavioral therapy. So, we have basic techniques, and we just need to remember that there are 2 main components: cognition and behavioral change, along with understanding sleep hygiene, the factors affecting sleep, and what cognitions are not suitable for sleep. These are the basics that all doctors and healthcare workers can provide to patients. Alternatively, at a higher level, we can use online programs or tools for patients to self-monitor, where patients enter their bedtime, wake time, and so on. Patients have apps, but they are currently mostly in English. At higher steps, they would meet doctors specializing in sleep or psychologists trained in CBTI. There will be interventions that can be group-based, which saves more time for healthcare workers, as well as one-on-one sessions for difficult cases. Each CBTI session typically lasts from at least 30 to 60 minutes, with 45 minutes on average. It should be repeated every 1 or 2 weeks because it involves habits, so we cannot leave too long of a gap. Otherwise, the patient loses that habit and the treatment will not be effective. In summary, CBT is a psychological therapy, and as its name implies, it involves both cognition and behavior. It can be applied to insomnia, OSA, and a number of other sleep disorders. It can also be applied to problems regarding nightmares. However, for nightmares, there are specific techniques tailored to them. Medical personnel can use some techniques from CBTI to basically help patients understand their condition, how it should be treated, how to be compliant, and what behaviors to adopt for better treatment adherence. Specifically for comorbid insomnia and OSA, CBTI is recommended as the first-line treatment for chronic insomnia. Why not for acute insomnia? Actually, because in acute cases, patients have not experienced enough of the discomfort of insomnia to accept this therapy. Therefore, medication is used more often for acute cases, though, in reality, CBTI can be applied to acute insomnia as well if we can convince the patient. There are many levels of cognitive behavioral intervention, from patient self-education through media channels, education by general practitioners, to intensive interventions by psychologists or medical personnel trained in CBTI. We have upcoming programs that we hope to implement with the Vietnam Insomnia Association and the Vietnam Sleep Medicine Society to conduct intensive practical training for insomnia treatment. If you are interested, you can scan the QR code to join our interest groups before we begin the intensive training courses. Yes, thank you, everyone and professors, for following today's presentation.